I'm sorry we have to start on this note, but it is a reality. 1,141 suspected and 65 confirmed cases of cholera, 30 deaths, and 996 local government in 30 states between the 1st of January and the 11th of June this year. Certainly something very, very concerning. On Tuesday, we understand that the Lagos State government said at least 5 people were reported dead in the state as a result of the outbreak, and while 60 were admitted. I have also good information, credible information to tell you that we understand that those who are on admission, they're doing fairly well, and there have been no new cases according to an official of the Lagos State government. Well, this is not just something about Lagos, it's something of a national spread. So let's talk with the Director General, Nigeria Center for Disease Control, Dr. Jide Idris. He's here with us. Thank you so much for your time today.
My pleasure, Ayo. Wow. Nice to see you again.
Same here. So you haven't been here in 10 years. So
do we have to go through that now?
Unfortunately, there's something else we are going through, which is this cholera outbreak. It definitely is concerning, isn't it?
Oh, definitely, definitely. And it's sad to say is, okay, we've been monitoring it throughout the year. It's one of those diseases that occur throughout the year. Oh. But we monitor the number of cases, but once the cases start rising, and more than usual, there is an alarm. So in this 24th week, the increase is quite high. And when we got the news from Lagos State, looked at the data. I mean, there are 2 states now that have very high cases, Lagos and Bayelsa. And like rightly said, 30 people have died, which is very bad. And then that's why, and our people, I mean, NCDC, we're monitoring the situation. Right now, we're doing a risk assessment. Basically, we've sent a team down to Lagos now, came in yesterday or 2 days ago, to work with the Lagos State government and assess the level of risk, the situation, how many people died, what their capabilities are to address the situation. Then we take a decision in Abuja and see how best we can help. But we've sent out alerts to all the other states, what to do. The same thing we sent out to all the other states. And the states themselves to basically need to do their own work at the various levels there, because it can't be everywhere. It's a sad thing. People need to, well, to me, it's a disease that is bordering on basic sanitation.
Which leads me to a question. My apologies for butting in. And it's something that's been of concern. As I mentioned earlier, while I was opening the program, one of my colleagues said that she spoke with a health officer who said that it seemed that the government, be it federal or state, kind of moved from preventive health to curative health, and said that she actually spoke with someone, because what we had before, because I was talking about that with her, what we had before was a situation where environmental officers, health officers went from local government agencies and went to the nooks and crannies, entered into people's homes.
Definitely.
And they ensured that, look, if your sanitation was awry, they called you out, they penalized you. In fact, if your water had tadpoles back in the time, they broke the pots and you had to go get another one. Something was being done at the time. It would seem like, I don't know if that's still ongoing.
Sadly, I don't think so, because I'll tell you, when I got into NCDC, I looked at what was going on, I mean, how they were doing things, and it struck me, our mandate is health security, and borders on prevention, surveillance, detection, and response. But that full level, my observation is that the first level, that prevention, it's very weak, which also buttresses your point that we seem to have forgotten the need for prevention, or we're not taking it very, very seriously. And in a situation where resources are limited, I think that's the best approach. Now, when you say prevention, over the years, you say, well, health education, don't do this, don't do that. But it goes much more than that. If you go back to this cholera case, to me, it's a problem of poor sanitation, both personal and environmental. It's a profession of lack of access to water. And now, the easiest way to do all this good personal hygiene, hand washing, especially after using the toilet and that after before you cook your food. But the situation where you tell people to do hand washing and there is no access to water, it's a problem. So I think everybody, including federal government, state government, different agencies, local governments, even the people themselves, the community have to come around. It's not just enough. The state government have to provide, where you don't have the good pipe-borne water, you cannot provide maybe tankers of water, clean water for people where they are. You can provide portable toilets where they can, because the commonest practice here, especially in the slum areas where you have all these cases, is open defecation, poor personal hygiene. Now, if you tell the person not to defecate openly, you must provide an alternative. No, you understand me? So it's everybody's problem.
You know, one of the things that stands out in all that you have said is we seem to have dialed down on prevention.
Definitely.
That speaks to something, Dr. Idris. It speaks to the responsibility of the states. I know, I mean, as a federal agent, you don't want to poo-poo any state government and all of that, but it would seem like that is what it is, because there are those who point to the fact that one of the functions, constitutional responsibilities of local government organizations or local government agencies is to ensure that they do this, what back in time was called willy-willy. Definitely. And they had names like that, you know, in the north, in the east, everywhere else.
Environmental officers.
Environmental officers officially. So do you see them still in action now? If that's a gap, why is it taking us some kind of rocket science?
What I would say, it could be better. One, we need to train more of those officers at the local government level to work at the local government level. I know there are many schools of, health technologies where these categories of workers are produced. But more importantly, I think it's also related to the issue of funding of the health sector. You have very poor funding, then human resources are getting worse. That's the reality. Everywhere, at different levels. You know, everybody's talking about Jackpot syndrome. Something needs to be done. Because it's the same people that have to work to do this work. And the other bit is we ourselves, individuals, we need to have positive health-seeking behavior. Because there's a limit to what government can do if we ourselves do not take our own health very seriously. And this is where, so we need to change our behavior. And this is where health education comes in. But it has to be done in a way that it is culturally sensitive. You provide the same messages to the people so that they can fully understand. It's not just enough, do this, do this, do this. You need to get people within, that's why the community tool, that's a community mobilization. Look at community leaders, people who understand the communities, get them involved in propagating these things. They are the people who can give you information. That we have surveillance now. Everybody can be in every nook and cranny of the states. But it's the same information we get from the community will help us to track some of these. It is the same information, same people can use now to pass on information to the people. So it's a combination of many things. But like I said, health is everybody's business. Government has a role to play. We people have our own role to play.
Now, it also goes to recognize another significant issue. I mean, I'm glad you mentioned the fact that one, it's everybody's business, and you mentioned the 4 general criteria that primary responsibilities of the NCDC. Still talking about the prevention, Dr. Idris, there is a place of primary health care.
Yep.
There are those who would say, look, maybe access is also a problem. For the life of me, all my career, I've been hearing about primary health care development. And it's not like we don't have them. What do you think is the problem? How significant a gap is that in what we're talking about here?
And to be honest, it's a huge gap, over the years. And I think the primary healthcare system had been, to me, has been neglected, so to speak. But again, I will speak for this government now. They've taken health they made health a priority. And they are doing all their best to address this. So primary health care is one of the major focus. And I think it's receiving serious attention. But the fact is that all over this country, there is serious inequity. There are some states have the resources most states don't have. You can have the facilities built or whatever it is, you don't have people to man them. And this is where, again, primary healthcare comes, people themselves, you have to use people within the communities to address these issues. But it also goes to the fact that you look at the community, each community, you have to assess their vulnerabilities, the kind of capacities they have, the resources, their culture, what goes social determinants of health. They're different from different states. So it's not one size fits all. So what you do in terms of communication in a particular state may not work in another state. So into language barrier, culture issues, tradition, etc. So you understand me? So, and this is where at that level of care, these things come into play. Unfortunately, like Riley said over the years, these things have not been funded or they've not been addressed. But I guess with the present government, it's going to take a while because attention is being drawn into all these areas.
Now, let's quickly go back to cholera, because I know that cholera, we can just say, is just one of such issues that the NCDC has to deal with. In the statement, your statement you put out, you said that the 10 states that have contributed 90%
definitely
of the burden include Bayelsa, Zamfara, Abia, Cross River,
Lagos,
Bauchi, Delta, Kaduna, Imo, Nasarawa, and Lagos states. How would you describe the level of involvement, engagement, or activity from each of these states in taking down the numbers and, if possible, wiping them?
I know, look at the trends. In fact, 7 of the states, there is a downward trend, I must speak, in the last 6 months. But again, that's why we were sending people out now, just to do rapid assessment. The assessment is that, you have some experts who go to the states, assess their capabilities to manage the situation, what gaps they have, what facilities they have, and that kind of thing. Based on that, we determine how to assist. But meanwhile, we've sent out materials to different states involving including what they need to use, IV fluids for people having diarrhea, what is to test, rapid test kits, and I think the minister too is talking to provide again the necessary vaccines for cholera vaccines distributed to various, but each state again has to be responsible for their activities.
Do you see them taking enough proactive action?
Well, enough. But I wouldn't say, because that's why we need to assess what they have, capabilities they have.
Sometimes there is another issue a number of people usually have with when we hear all these things. We only hear about it. It goes back to the issue of prevention we're talking about. We only hear about them when they're getting worse. Do you see any plan from your assessments? Again, I understand you are a federal agent, but at the same time, people need to know so that if it is possible, the people themselves can take enough preventive action. So do you see any significant plan on the parts of the states, all 36 of them, in ensuring that these things don't get worse until the NCDC has to step in?
Well, many states have plans. Whether they can fully implement those plans, I don't know, because they have, because of the resources they have, that might be in place. I know that most of the things they've been talking about has to be issue of funding, human resource issues. But one thing, when I got to NCDC, there was this beautiful seasonal calendar. You have on the left side, you have all the diseases, the endemic disease in Nigeria here, January to February. So we know when this is going to occur. But they still occur. And the problem is that's where, again, butters the point that prevention is key. So when just for instance, now NIMET has said that the rains this year is going to be heavier. You understand me? And when you have rains, you are going to have flood, and you're going to have contamination of our water sources. So the chances are that diarrhea cases will increase. So at least now that we should start preparing, most states should start preparing for things like this. The flood-prone areas they need to address. They need to stockpile what they need to treat. They need to provide all those facilities, get the facilities ready. This is the level of preparedness we are talking to the states to develop, to start putting in place.
I'm looking at your website now, the website of the NCDC, to buttress some things that you've just talked about.
Yeah.
We have 2,655 cases of cholera. Lassa fever has 2,565. Measles has more than 12,000.
Yep.
We knew these things were going to happen.
Definitely.
And they happen in the states.
We're just saying the same thing. So we need to address the issue of prevention now. It's key.
How?
How?
Idris?
Now what we do, okay, you know the season, you know when it's going to start, and you know when the season goes down. From the time it goes down to the next time you expect it, you start these preventing activities.
What did we do before now? My apologies for putting it. That we stopped doing.
Let me say that I've been in retirement for quite a while.
Now I'm talking about even before you got into public service.
No, well, I think the local governments were more active than they are right now. That's one. Two, those times they had people who were very knowledgeable in public health to man the local government facilities, unlike what the situation is right now. You understand me? I remember when I first got to Lagos, most of the people heading the primary health care facilities were public health specialists. So they knew precisely what to do. It's not the same thing in most states. It's just now you're trying to get people to know when you want to recruit. You recruit the appropriate specialist or human resource to handle what they should handle. Like again, in this country, we tend to more involved in curative care. Like I said, that's just about 20% of the health sector. Public health is key because it now deals with population health. Anything can happen, can wipe out so many people. We don't pray for it if public health is not addressed. And you can't have good public health issues. You have to address the issue of water, the issue of sanitation, the issue of waste disposal. These are not the purview of the health sector. But again, that's why now we're talking on one health issues. The health sector, the environment, and the agri need to work together, water resources, to be able to effectively provide for our people. And policies must be aligned. Activities must be aligned. That's the way we are going now, nationally and statewide. That's what we are propagating now. Because you still doing the health. For example, most of these diseases are caused by diseases of animals. Ebola, COVID, yellow fever, all those are diseases of animals that found themselves to humans. So even if we treat a human being, it does not stop the transmission. Unless, of course, you deal with the disease with the animals and say, even environment now is an issue. So the environment, we create this environment that allows these organisms to thrive or to be able to, affect people. So it's a whole gamut of things. And when you put the right people, right specialists there to do things properly, that's when you can begin to get results. The clinicians are trained to treat diseases. Once you treat them, the people go back into the environment. You still not address that problem.
Now, you said some of these things happen in phases, in cycles.
Yeah.
Right now, we are dealing with cholera. And from the figures on your website, Lassa fever seems to be almost in competition with cholera.
Yes.
But measles...
Since we've been dealing with 5 major outbreaks. Meningitis, Lassa fever, measles, diphtheria, and cholera. It doesn't mean that you don't have the other disease, but at a much, much lower level. But again, there are hotspots in this country, not all states. So those hotspots, they have some peculiarities that make those things thrive. And again, depending on the type of diseases, what is causing disease. So some areas, more admitted to some particular diseases. Take, for instance, Lassa fever. The disease is carried by rats in some specific areas of our country here. And that's why they're called hotspots. So you need to deal with the agric people, environment people, and then engage the community on how to actually protect themselves through personal and environmental hygiene. And some of our occupational practices are there. In those places, they spread food on the floor, either to dry. This is where these rats come in to eat. And in the process of eating, they leave their droppings that can cause these diseases. So that's how this is transmitted. So you need to break the transmission in a way. And this is how so everybody must work together. The health officials cannot start chasing rats. It's the work of the, agri people, Ministry of Agriculture, environment. You understand? But that's why everybody must work together. For diarrhea, you need water source. You need sanitary facilities. Apart from educating the people. If people learn to cultivate the habit of washing hands, hand washing alone, after in the bathroom and that kind of thing, or before cooking, after cooking, it reduces the chances of this diarrhea disease by almost 40%. Easy. But getting them to do that is one. And even we get them to do that, if they don't have access to that basic things, water, it's a problem. Just like that, like I said, open defecation. If there are no toilet facilities, the chance that some people who don't have the means and that kind of, all they do, they go to the open. So I think it's work in progress, but the more we sensitize people, the more we work with the subnational, the state government, local governments, so that we all come together and address these issues one way.
I know that some of the questions that I've asked, they are not really yours to answer. Primary health, for instance, we have an agency for that. You talked about the collaboration that has to happen with agriculture, water resources, and all of that.
Primary health care is involved. They deal with vaccines generally. They are looking into these cholera vaccines. They also have, most of the primary health care facilities are directly under them. I think they're working hand in hand with the primary care facilities.
Well, the reason I'm even asking is, I'm raising this issue so that people know that at least, there is a lot of collaboration that needs to happen.
Definitely.
Now, this sensitization, whose job is it? I know that NCDC has just a fraction of that work to do, but the people live in the states, and there are government agencies, federal and states, that have the job of orientation and all of that to do. Perhaps sometimes it's in the way the information is passed to the people. One of the issues that that's giving me concern is among the young people, Dr. Idris. It would seem like a host of things that we talk about, we don't even talk about them a lot. So how do we collaborate? How do we coin our communication in a way that young people can own them and also pass them on to other people?
You're very right. I think 2 weeks ago I met with the media executives. And the reason being that with our health professionals, we're not good with communications. And if you want to do this properly, you need to talk to specialists. And that's why that engagement was necessary. They know how to, you give them the information, they know how to word the messages, and they know how to pass on the messages. Like Riley said again, our children, things like this need to be taught in schools. School health programs are very key in things like this. It's at that level of life they inculcate good behavioral practices, personal hygiene. I do that. I think they taught us when we were in school. I mean, when we were young in those days. These things need to be revived. They need to be revived. There's no doubt about that. And like I said, health is a collaborative agenda. Everybody must be involved because everybody has health issue, must be involved in health. Communications people, even drama people, because they have very good ways of communicating with people that we health people can't do that. And most times, again, we speak the grammar or whatever it is that they don't, we're too technical.
Okay, just this one thing, perhaps talking holistically now. And you talked about the challenge of funding. What is the standard that you think is best? Is it WHO or UN recommended percentage that any government, federal or state, should allot to health? And how well are we doing?
I've had this question posed to me a long time ago. I don't believe in that thing. Okay. Because you cannot sit in Geneva and you don't understand our situation here, and you say you should provide 15% of your budget to health. You understand me? You may need more than that. But again, you need to understand the local situation. So I think it's left to the government themselves. Again, the issue here is that most of the people who head the health institutions, I don't know where they have the rapport to the powers that be. And if you don't have that rapport, your work is difficult. Because getting your budget, especially in this country, is serious work. And if the people who allocate the resources do not even understand the issue you're raising, it's very difficult for them to even allocate funding to it. So, but they recommend 15%. But again, if you look at it, health is not a cheap It's an expensive business. Even the prevention aspect of it is expensive. Because you have to craft the messages, you have to disseminate, and you have to study the people, social people to write properly. It's expensive.
So if you would recommend, from your experience, having worked in the health space in various capacities, and now as DG of NCDC, what would you recommend?
That's a tough question.
Well, you just said also that health is very important.
Yes, no matter what you recommend, it depends on the resources available to government.
But if it's standard, what would you normally?
I will go by WHO 15%, but if the government can even provide 10% of that to start with, and it's not left for the people in the sector to use that money judiciously, address specific priority issues, it goes a long way to do this.
But from what you are aware of, would you how would you rate our performance? Would you say we are anywhere near that 10%? Would you say we are prioritizing health where we should?
At the federal level, in the past, we've not gone beyond 5%, 5-6%. That's a maximum. And I think even with the current government, but you can understand again now the economy is poor. So it's not easy to do that. In some states, there are some states who've actually allocated more than 15%. But again, you haven't seen anything to show for it. You understand me? So there is no one formula. I think it depends on the sincerity of the people in government. It depends on the data available to you and the way you prioritize your issues. I mean, there is no point in going to build a big health security facility when your people don't have basic water, basic sanitation, basic. It's stupid. Because I mean, like Ryan said some time ago, I said our system is geared towards making people sick. And some people attacked me. I said, because this guy has malaria. He comes to you, you treat him. He goes away, he's going to come back. Because you haven't addressed it.
Well, you talked about the open defecation thing the other time, and very many people in different parts of Nigeria now are remembering one location or the other where people openly defecate.
Yeah.
Case in point is the Lagos-Ibadan Expressway.
Yes.
Just not too far from us now. I mean, the federal government just finished the construction and made beautiful medians on the road. But what we have is like now a space for many people to openly defecate. So what do you think can be done?
Because in planning, it's not just to plan the roads. You plan for the people using the roads. You carry people around. There's some point in building fine roads, building everything when there are no sanitary facilities for them to use. You understand me? I mean, people have physiological reactions. You don't plan for it. But
so we're going to have to live with this?
No, we don't have to. I mean, what's that? People, government must learn to plan properly for things like this. You me. I mean, there is need for sanitary facilities. But again, in some places where they built this, they were not properly maintained. Or people misuse them. So it's a major part. Just education, again, is key. Behavior change is key. And again, that's where people who are good in communication, people who are in all these things, must come together and say how to.
Okay.
You have to change behavior.
When I was growing up, we had a lot of public service announcements, always telling people one thing or the other. So it all goes back to communication. That's what you're saying. Okay. I guess we can say this is step one. Dr. Jide Idris, Director General, Nigeria's Center for Disease Control. Thank you so much for your time today.
My pleasure. Nice to see you again.
Education. Yes, sir. So we take a short break. When we return, don't forget I told you it's Idil Fitri. Is it Idil? Idil, what is it? We'll find out when we return.